Hi, everybody. My name is Micaela Crowley, and I am an optometrist who practices at Lexington Eye Associates in Massachusetts. And today we are going to talk about the Onefit family of contact lenses and really how it can specifically help our dry eye patients. So the Onefit family of lenses is a scleral contact lens that Blanchard has created, which has really evolved since it has been introduced to the market. It started as the Onefit design and has evolved to the Onefit Med and Onefit Med Plus designs, which every single time they make a different lens, they've really made it so that we can more highly customize it for our patients. Now the Onefit Med Plus is available in a larger diameter lens, and it also has the ability to offer quadrant-specific edges as well as quadrant-specific limbal zones, a mid-peripheral zone, as well as different sag heights. So when we are ordering the scleral contact lens, there are 4 specific fitting zones that we need to specify when ordering the lens. The first one, and arguably the easiest one, is probably the sag height, because we need to make sure that that sag or the lens completely vaults over the cornea. So it depends on whether or not you are fitting a patient with keratoconus or an irregular cornea for ocular surface disease, or whether or not you're fitting a post-refractive surgery patient. The sag must cover the entire area of the cornea so that there is no touch any area on that cornea. The next zone is the mid-peripheral zone, which is really helpful to specify, especially for patients who are post-graft corneal transplant patients. And I find that the mid-peripheral zone, being able to customize that area for post-ectatic graft is really helpful, so that you can make sure that as that lens settles on the eye, it's not going to cause any areas where it is actually touching the cornea. The next area to specify is the limbal zone, or the limbal value, which we know is a really important area to maintain the health and physiology of the eyes. At the area of the limbus, we need to have enough clearance over the limbus so that we don't have any inflammation or areas of compromise of those precious limbal stem cells. However, we don't want to have too much where it causes not enough oxygen to that limbal area so that it can cause swelling that way too. So it's a really important area for us to specify and make sure that there's not too much, but not too little. And then lastly, which I would say might be one of the harder areas to fit when fitting a scleral lens, is that landing zone or the edge design. And the reason why is that everybody's eye is shaped different. The sclera, there's asymmetry, toricity, there's areas of pingueculae, areas where it just might not contour perfectly. But with a quadrant-specific zone, you should be able to get it, opposed really well to that sclera. There's also an area when looking at scleral lenses called the primary functional diameter of the lens, or the PFDL. The PFDL is where the limbal zone meets the landing zone. And why is this important? Well, it's important because we need to be able to know that we can change that edge design without it influencing the fit of the rest of the lens. So this means that if you come in and everything looks perfect on somebody's eye, you can still change that edge without it having an effect to the rest of the fit. It's also important with modern technology for fitting techniques such as scleroprofilometry, where it'll allow you to more customize based on what that profilometry will give you for values to highly customize the lens on the surface of the eye or on the sclera. When you are fitting the lens, the Onefit family comes with a diagnostic lens set that makes it really great and easy for us to identify exactly where each of these zones are. So the first marking that's available, one, they're all etched. So you can see on this bottom photo here, where you see that eye with the fluorescein in it, you can see those etched marks. Well, that is your mid-peripheral zone on that inner portion here, and then the limbal zone is the next one. Now, if you have technology such as OCT, where you have the capability of identifying how much clearance is at each mark by the OCT. There's also indentations that you can appreciate on OCT so that you can highly specify or exactly give the precise measurement right at that mid-peripheral and limbal zone, as well as the central corneal zone here. So what are we supposed to have as our clearance areas? What is the appropriate measurement? When we are looking to assess the ideal clearance, there's two specific times in the initial fit that I always like to assess before making my first order of the lens. One is the initial application. When you first put the lens on the eye, at that central zone, really over the highest elevation or the steepest area of the eye. So that would be over the steepest, if you're fitting a keratoconus patient, where is that cone steepest? You want to make sure that you have between 250 to 300 microns over that steepest point. So no, not necessary to go to that OCT for this per se. And the reason why is that you can very easily eye it because the lens thickness is about 250 microns. So that section of the tear reservoir should equal the thickness of that scleral contact lens. So that's a really good way to determine whether or not you have a good start initially for your SAG measurement. Then I look after about 30 to 45 minutes. Really about 30 minutes because patients are already in our offices for a long amount of time. But at that 30-minute point is where I really look at the detail of the fit of the lens. This is going to tell you if the lens is centered on the eye, it's going to be settled in appropriate amount. You really want to have between 200 and 225 microns over that steepest elevation of the cornea. But this is also when I draw. I make tons of drawings. I have the patient look up, down. I have them look various ways. I have them blink to make sure that there's no movement of the lens. And I also will put a drop of lissamine green over the surface of the lens to see if there's any area where there's tear exchange underneath the edge. And that's going to allow me to customize the lens for that patient at that edge zone and minimize the chance of fogging happening with the lens. So again, really important for that landing zone or that scleral alignment. The reason why it's important to have appropriate scleral alignment on a scleral lens is because it can cause decentration of the lens. And what that could mean or result is something called conjunctival prolapse, which is when, especially for people with dry eye, they might have a more delicate surface of the eye and might have a susceptibility of having what we would call a boggy conjunctiva or conjunctival chalasis, where that boggy conjunctiva could get stuck underneath the scleral lens. And decentration of the lens could almost cause it to get pulled into that area. So having a more centered lens is going to reduce the risk of having conjunctival prolapse. One thing that I probably learned early on, and probably by trial and error, was really that if decentration, it can induce residual astigmatism. And so this might be the case where you just keep on chasing that over refraction. You get that lens and you put it on the eye and it looks like it might be centered, or it might be just a little decentered, and you're getting a cylindrical over refraction that really just doesn't make sense. You order it, and then the patient comes in, you put the lens on the eye, and they say it's just not clear. And what's happening is it's inducing a lot of aberration because that optic zone is lower, and it's creating more of an aberration than it is a correction. So in order to have that lens not induce the residual astigmatism, is if you had just a centered lens, that might reduce your need to have to correct that. A misaligned landing zone can also cause fogging. And depending on the extent of misalignment, the fogging could happen, 30 minutes after the patient puts the lens on the eye, or even up to 3 hours after the patient puts the lens on the eye. But this can be a really frustrating thing for our patients and really practitioners too, just to try to reduce the amount of midday fogging so that the patients don't have to be burdened by having to take the lens off and put it back on the eye midday. So another trick, so like I had mentioned already before, is we're already having that fluorescein on the eye when in that fluid reservoir. So you could just put lissamine green over, put a good amount on the surface of the lens, and within seconds you'll see if that lissamine green is leaking through the lens. And that's something called tear exchange. And the reason why it creates fogging is because our tears are very metabolic. They have a lot of immuno properties, proteins, electrolytes, and when we blink, we process that off the surface of the eye and it doesn't cause clouding. However, when it gets stuck underneath that scleral contact lens, it creates a very cloudy environment because it's stagnant and not moving. So making sure that that landing zone is aligned is really going to minimize the risk or the incidence of midday fogging. Having a misaligned landing zone could also cause discomfort for the patient, and they will most definitely let you know when this is happening, especially if it's a little too loose or creating some lift or a little flat. They will catch that every single time they blink, and it will be a real significant nuisance. So it's really nice after that 30-minute period to just look at the patient after the lens is already settled in and say, do you feel it? Where do you feel it? And very frequently they'll be able to describe where they feel it, right here or underneath here. And that will allow you to look at exactly where that issue might be at that edge area. And it could also cause, blanching or standoff, depending on whether or not that lens or that landing zone is too steep or too flat, which that will be indicated by, the conjunctival vasculature where that lens opposes the eye. So this is a good example of decentration causing residual astigmatism, where if you look at the photo on the left, you'll see that that lens is decentered by having a fluid reservoir or an optic section or fluid reservoir that is just thicker on the bottom portion compared to that top portion. And you can see that the patient's vision was 20/20 minus, and they were probably having a little bit of that aberration. And then when you centered the lens by changing that landing zone and just making the lens go to the appropriate area, that patient was able to achieve 20/15 vision without that astigmatic correction. So now let's move into talking about scleral contact lenses with regards to dry eye treatment. And for dry eye patients, we know that dry eye is a multifactorial condition. There are various causes for it, various triggers for it, environmental causes, systemic causes, inflammatory and evaporative causes. But whatever the reason is, the patients are uncomfortable because there's a loss of homeostasis on the surface of the eye. And there are various treatment options for them. And in certain circumstances, scleral contact lenses can be an absolutely wonderful treatment option for these patients. And the reason why is that it creates constant moisture to the surface of the eye. So let's talk about, who would benefit from scleral contact lenses and why, who's going to pay for these scleral lenses, and how do I best utilize the Onefit Med family for my dry eye patients. So who specifically would benefit from them? Definitely post-refractive corneas. And the reason why is that post-refractive corneas tend to be irregular, right? It's just the nature of how the treatment is. So when you put a scleral lens on the eye, the way that I describe it to patients is that it's going to fill in all of those areas of irregularity. So it's going to fill in and create or mimic a smooth cornea. Also, patients with corneal disease, ocular surface disease, greatly benefit from scleral contact lenses. One, it could be because it's going to, again, fill in those areas of irregularity, but then it's also going to be therapeutic for the surface of the eye by always delivering moisture to the surface of the eye. And then one that is an absolute slam dunk when it comes to patients with dry eye are those who suffer from exposure keratitis, because it delivers moisture to the surface of the eye constantly, rather than them having to, put artificial tears on the surface of their eye or ointment, which could blur their vision even more. So some of the specific conditions that are great or who would benefit from scleral contact lenses are, again, the patients with exposure keratitis, because it will constantly deliver the moisture to the eye. Instead of them having that exposure from an incomplete blink, they'll have something that's delivering the moisture, so that there's no exposure when the person cannot blink. Another one is Sjogren's syndrome, and these people very frequently, despite being on maximum therapy, are going to say that they are using preservative-free artificial tears every hour. And a scleral contact lens could be a great option for them, because again, it's going to constantly deliver that moisture to the surface of the eye. It'll essentially bathe the surface of the eye. And especially if you use a larger diameter lens, that will offer more surface area of the eye that's being treated or covered with that lubrication. Filamentary keratitis is another condition where I have a few of patients with filamentary keratitis and scleral contact lenses, and it truly is life-changing for them. Instead of their eyelid having that, irritation or that foreign body sensation or creating more friction on the surface of the cornea, that scleral contact lens is going to create a moist environment, so that they don't have that foreign body sensation all day long. It's really a touching moment when they first put this lens on the eye, because it gives them almost immediate relief. So these patients are highly motivated to wear the scleral lenses because of this. Two other conditions are ocular graft versus host disease, as well as Stevens-Johnson syndrome. Again, just treating that ocular surface. Two others are limbal stem cell deficiency, as well as neurotrophic keratopathy, where this can provide comfort and therapy to maintain the integrity of the surface of the eye, but it can also provide the patient with clearer vision too. Some other more generic types of dry eye would be meibomian gland dysfunction, as well as just traditional soft contact lens intolerance, where the person might just need the scleral lens to give them more comfort throughout the day. So they work as a cover shell. That's what we were just talking about, and that's why they can be beneficial for these types of ocular surface disease. So I always describe it to my patients that it's almost like a bath for the surface of the eye. We are putting preservative-free saline, and in some cases, some artificial tears in that bowl of the lens, so that it's constantly delivering moisture to the surface of the eye. It's going to also protect the surface of the eye, from the eyelid, from the air, from exposure. So it can work as an actual therapy for various types of conditions too. So I always like to tell them that while I do expect it to improve vision some, that might not necessarily be our primary objective. Our primary goal is to make your eye healthier by delivering the moisture to the surface of the eye. So there are certainly some special considerations for fitting scleral contact lenses for dry eye patients. And one of them is that they might be frustrated by the time they see you, because they could have seen several doctors prior to coming in to your appointment. So they might feel exhausted, and it's one of those conversations that you have to have and set realistic expectations, saying, well, this is going to be a process. This will make your eyes feel better because of X, Y, Z. However, it is a commitment, and we will see each other quite a bit in these next however many months to get the appropriate fit, specific and customized to your eye. I always try to emphasize that this is a medical treatment, a therapy for their dry eye disease, as opposed to, a vision improvement. I also discuss long-term wear in saying that my 3 goals when fitting this lens are to provide clear vision, to provide comfort all day long, and then to maintain the physiology and to meet the metabolic demands of the eye, so that we can make sure that you can wear these scleral contact lenses for the rest of your life, comfortably and without any issues. And I always, always, always forewarn patients about fogging and debris buildup. And this is because, it could be an issue, especially with dry eye, and especially in the early stages of their therapy, where they could just be coming back to a healthier ocular surface. So they might have more fogging in that early stage compared to when they've been wearing it, for 6 months or so. So, some other considerations are really that these patients have delicate eyes, right? They have dry eyes, they have ocular surface disease. So, there might be some differences that we need to make in the fit of the lens compared to somebody that might have an ectatic cornea. So, we need to have uniform clearance. The uniform clearance needs to be over the cornea as well as over the limbus. So, as far as the limbal health, again, we need to make sure that there's not too much and not too little so that it doesn't create inflammation or loss of integrity of those precious limbal stem cells. We may also want to consider that we want to fit the edges a little bit looser so that it does not create that extra suction force when the patient is removing the lens. And I always, especially for my ocular surface and dry eye disease patients, I always go for the larger diameter lens. And again, the reason why is because it's going to provide more of a therapeutic area to cover. So let's go over some cases. My first case is a 70-year-old female she is that dry eye patient who has gone to multiple doctors and had multiple different therapies before she came in. And she was just really frustrated with the fact that her eyes are constantly dry, and it was really decreasing her quality of life and the way that she was living. She had constant dry eye symptoms for years, a constant foreign body sensation, burning all day long, and then redness. The redness was especially bothersome because it was embarrassing. It was making it so that she couldn't look people in the eye. She didn't want to go to certain social events because her eyes looked red and they were bothered all day long. So, some really pertinent surgical history, ocular history, was that she had PRK. So, there's probably some level of neurotrophic component to her dry eye disease, although not exclusively. She has had cataract surgery. Her cataract surgery was a great success. The intraocular lens implants were well centered. There was no PCO. It wasn't, causing any vision issues. She was really, great with monovision. So did not have to wear glasses after the cataract surgery, and very happy with that. But she always complained about fluctuating vision due to the dry eye. And the last surgical history that she's had is a blepharoplasty. And sure enough, when I looked at the slit lamp exam, I saw a confluent 2 to 3 plus inferior punctate keratitis with incomplete eyelid closure. And her eyelid closure was such that she couldn't even force the lids to close. So there was constant exposure, even when she was blinking. So we talked about options, and she's gone through prior treatments, various prior treatments. Again, has gone to various people, and she's had punctal plugs, and she's been on preservative-free artificial tears, putting them in every hour just to provide some lubrication to the surface of the eye. She was using artificial tear ointment at bedtime. She's been on cyclosporin and lifitegrast, and they just caused burning to the eyes, and she could not tolerate the side effects from when she was putting the drops in. She had gone through an amniotic membrane graft, which she had really great success with regards to providing clear vision. However, of course, it was only temporary improvement because the nature of her problem was that she had exposure of that area from the incomplete eyelid closure. So we had discussed perhaps trying autologous serum, however, deferred because again, the main issue here was that there was incomplete closure and an exposure keratitis after the blepharoplasty surgery. So the treatment that we decided to go for was to just maintain eyelid hygiene, artificial tear ointment before bed, and preservative-free artificial tears, but the main one was a scleral contact lens. So we fit in a scleral contact lens, and there was great success. It's provided clear, comfortable vision all day long, and with the improvement of the ocular surface, there's been a complete reduction in the redness of the surface of the eye. So no more having to use any type of redness relief drops, using preservative-free artificial tears as needed. One thing to mention is that we did try moisture chamber goggles for sleeping. However, it did interfere a little bit too much with just sleeping pattern. So, of course, just went to the ointment before bed and the scleral contact lenses throughout the day. So this person has been in the scleral contact lenses for many years successfully, and it's really been the only thing that's treated the dry eye symptoms and the ocular surface disease that she has from the exposure. So one of the things, though, that is a complaint that we do have to establish up front is the potential for surface debris accumulating on the surface of the lens. So the person will come in and say, they're great. My symptoms are completely gone. I'm comfortable all day, but I still need to take this lens out after about really 3 to 4 hours and to clean it. And the reason why is that just as there was exposure on the cornea, there's also exposure on that scleral contact lens. So where the lids are not coming together, it's creating accumulation of debris. So that's one thing that really it's important to establish that realistic expectation and say, I want you to make sure that you bring this case with you everywhere you go so that you're never in a position where you can't take the lens out, give it a good clean, and put it back in the eye. And so that's a way that we have resolved that problem. And if you look, here's the patient's eyes. They are completely white. There is great apposition of that edge of the scleral alignment. You can't see or appreciate the debris, but there is a line of debris in this photo that I tried to capture and unfortunately could not. So who's going to pay for these lenses? We chatted a little bit about that. Well, it depends. It depends on what the reason for the scleral contact lenses are, whether it's medically necessary or just, for vision improvement. Usually the refractive fits are covered, and some medically necessary fits are covered by vision plans. And then one thing that I do want to forewarn everyone about is that if you do plan to use medical insurance for billing scleral contact lenses, you are obligated to take the contracted amount for the fit process and materials, various environmental exposures and hypersensitivities, and also a history of contact lens intolerance, both soft contact lenses as well as corneal RGP contact lenses. Looking at slit lamp exam, she did have conjunctival chalasis, which I find is very common in those who do suffer from chronic allergies, and then also a mild punctate keratitis. So the plan, it was appropriate to start on cyclosporin, as well as an omega-3 supplement and eyelid hygiene and artificial tears just as needed. But we also decided to move forward with a scleral contact lens so that we could deliver moisture to the surface of the eye all day long. And the scleral contact lenses and the whole entire treatment plan really have made the patient so that she can wear contact lenses again, and providing her comfort all day long in clear vision as well. So she had been wearing scleral contact lenses comfortably for a few years, and then a few, came in for her biannual scleral contact lens exam, and it was switched, or it was ordered with a different type of coating, so with a hydropeg coating, as well as switched to a clear care solution with the Hydroglide in it. And sure enough, those lenses were dispensed, and almost instantly when she put them on the eyes, started to get some redness and photophobia, and also some post-nasal drip and some nasal symptoms from having the contact lens on the eye. So it was thought that perhaps there was a hypersensitivity to either the Hydropeg or the Hydroglide in the Clear Care solution. So the lenses were reordered without the Hydropeg coating, and we stopped the Clear Care with Hydroglide and switched to a different type of hydrogen peroxide cleaning system without Hydroglide. And sure enough, about 2 weeks after that, came back and the symptoms were completely gone. So these were the eyes. As you can see, they are perfectly quiet, white and quiet. There is great edge alignment along that contact, the scleral contact lens on the sclera. And then you can also see that there's no redness, that the eye looks really healthy. So that was a success there for dry eye. So how can we best utilize the Onefit Med family of scleral contact lenses in our clinics? Well, we can use them for various ocular surface disease, dry eye disease, ectatic corneas, post-refractive. And it's also really nice that they are available in various different diameters to best fit, the size of the eye and the reason for why you're using the lens. It's also does not matter how many times I have fit these lenses and made adjustments to lenses. I always go to the fitting tool and I double check my work. Very frequently, we will make adjustments to the M value or the sag and not make adjustments to the power just because things get busy. Astigmatic correction. There's also the ability to have toric haptics as well as quadrant specific landing zone. They are available in multifocal optics for presbyopic patients, as well as an oblate design, which is really useful for patients who may have been post-refractive surgery, such as RK. They do, like I said, have the quadrant specific both landing as well as limbal zones so that you can customize the limbal area as well as that edge alignment to make it so that the patient's ocular physiology as well as comfort is maintained all day long. There is the ability to notch the edge of the scleral contact lens, and this would be in cases such as a pinguecula or a bleb surgery patient, where it's really useful so that you don't have impingement over that area, so that you can make sure that that bleb is still intact and working just fine. You do have the ability to add the HydraPeg, which is a great option specifically for dry eye patients. It has worked really great in clinic so that patients can have a smoother surface and less debris accumulation on the surface of that lens. So all of these different things, in addition to the way that you fit, will really allow you to maximize the oxygen delivery to the cornea so that you can maintain the integrity of the eye as well as those limbal stem cells. So what exactly, how do I best utilize the Onefit Med? Well, it's also available in multiple diameters. So this allows you to use it on various patients, whether, it's a smaller eye or it has ocular surface disease, or you need a larger diameter lens. There are various options. There's also a fitting tool that Blanchard offers on their website that I still to this day use on every single one of my patients every single time that I need to make an adjustment to that lens. And the reason why is that clinic can get busy and sometimes we just need to double check our work. It can be very easy to make a small adjustment to an M value or the sag value and then completely forget to compensate on that power. So by putting all of the information in that fitting tool guide, it's going to make it so that you don't make those mistakes and don't have to second guess, why did this work initially and now it's not working this time? You'll know that you did all of the appropriate changes. And then lastly, one of the most utilized features of this product is that the consultants are there to help us when we do need to troubleshoot and we do need to go through those really tough to fit eyes. They really can help us, help you. They're there for you, and they're more than willing to help with any questions that you may have. So thank you for listening. Thank you for watching and joining today. I hope that you enjoy the Onefit family as much as I do in my clinic.